Welcome to this explainer. Today, we're diving into one of the most fascinating and literally vital structures in the human body. I want you to think of the human heart not just as a muscle, but as a complex, brilliantly wired electrical house. Every single beat of your heart relies on a perfectly synchronized wave of electricity traveling through that house. But what happens when the electrical system shorts out? Okay, let's dive into this. Imagine the immediate chaos and the incredibly high stakes when the body's most critical electrical circuit just suddenly fails. The lights flicker, the power surges, or worse, the whole system just shuts down completely. In medicine, this kind of electrical malfunction is a literal life-or-death puzzle that clinicians have to solve in real time.
So before we get bogged down in the heavier pharmacological terminology, let's establish a really solid baseline. An arrhythmia is simply defined as a loss of cardiac rhythm, specifically an irregularity of the heartbeat. In other words, our perfectly timed electrical house has lost its metronome.
To make sense of all this, we're going to follow a straightforward roadmap today. We'll start with the heart's electrical anarchy, look at upper chamber chaos, drop down to lower chamber danger, explore what happens when the rhythm drops, and finally, open up the antiarrhythmic toolkit.
Section 1. The heart's electrical anarchy.
Now, what's really fascinating here is that this electrical anarchy doesn't look the same in everyone. It manifests in wildly different ways across patients. For one person, it might just be an unnoticed flutter or minor palpitations. But for someone else, it could mean dizziness, syncopal episodes, fainting, worsening heart failure, anginal chest pain, or all the way on the extreme end, pulseless hemodynamic collapse. The big takeaway for you here is that an electrical problem can be a silent nuisance or an instant, massive emergency.
Section 2. Upper chamber chaos.
We're walking up into the attic of our electrical house now to talk about supraventricular arrhythmias. And this perfectly illustrates the difference between two major chaotic events in the upper heart. Think about atrial fibrillation. We're talking about an incredibly rapid 400 to 600 disorganized beats per minute. This creates an irregular pulse. There is a total loss of that coordinated atrial contraction, or what we call the atrial kick. Contrast that directly against atrial flutter. It's slightly slower, around 270 to 330 beats per minute, but it's highly regular. Both are driven by re-entrant electrical circuits, often tied to structural heart disease or high adrenergic tone, but man, they feel very different at the pulse.
So how do clinicians actually wrangle atrial fibrillation back under control? Well, they follow a highly logical, step-by-step protocol. First up, evaluate the need for acute treatment. If the patient is hemodynamically unstable, they get a direct current cardioversion, literally shocking the system to reset it. If they are stable, we shift to rate control, using drugs like beta blockers or calcium channel blockers just to slow down that ventricular response. Step 2 is considering if we can restore the normal sinus rhythm. And step 3 is absolutely crucial, preventing long-term complications, specifically strokes caused by blood pooling up in those quivering upper chambers.
And that brings us to a magic number, 48. If a patient has been in atrial fibrillation for more than 48 hours, or if we just don't know how long it's been, the risk of a blood clot having formed in the atrium is incredibly high. Think about it. If we shock the heart back into a normal rhythm right away, that sudden, strong contraction could dislodge a clot and immediately cause a stroke. So past that 48-hour mark, patients require strict anticoagulation, using drugs like warfarin or dabigatran for at least 3 weeks before doctors will even attempt to reset the rhythm.
Section 3. Lower chamber danger.
Let's head down from the attic to the basement of the heart, the ventricles. This is where electrical failures escalate incredibly fast into true life-or-death emergencies. Here we have another vital number, 100. Ventricular tachycardia, or VT, is clinically defined by 3 or more repetitive premature ventricular complexes firing at a rate greater than 100 beats per minute. On an ECG, you'll see this as a wide QRS tachycardia. It can happen acutely because of severe electrolyte imbalances, like low potassium or magnesium, hypoxia, or a heart attack. And if it lasts longer than 30 seconds, that's considered sustained VT, and it puts the patient at extremely high risk for sudden death.
But if VT is dangerous, ventricular fibrillation is the absolute ultimate emergency. VFib is total electrical anarchy of the ventricle. The heart isn't pumping at all. It's literally just quivering. This results in absolutely zero cardiac output and instant cardiovascular collapse. In fact, sudden cardiac death happens most commonly in patients with coronary artery disease when this exact rhythm takes over. At this point, blood flow just stops completely and immediate CPR and defibrillation are absolutely required.
Section 4. When the rhythm drops.
Now as we transition away from those incredibly dangerous fast rhythms, let's consciously slow our pace down a bit. When the heart's power drops below 60 beats per minute, it's called sinus bradycardia. In a young, athletic person, this is completely normal and harmless. High vagal tone is just keeping the heart relaxed, but juxtapose that against an aging heart. The normal aging process can attenuate the sinoatrial node's function, leading to things like sick sinus syndrome or diffuse conduction disease like an AV block, where the signal gets delayed or even stopped altogether. If a patient starts experiencing dizziness, syncope, or confusion from this resulting low blood pressure, the definitive long-term treatment is slipping in a permanent electronic pacemaker to take over the electrical house.
Section 5. The Anti-Arrhythmic Toolkit. So how do we fix all this? Well, notice how beautifully structured this pharmacological toolbox actually is. This is the Vaughan-Williams classification system, and it shows how neatly the 4 classes of drugs align with specific mechanisms to manipulate the heart's electrical currents. Class 1 drugs target sodium channels to slow conduction velocity. Class 2 uses beta blockers for anti-adrenergic actions. Class 3 blocks potassium to prolong the refractory period, which essentially increases the reset time between beats. And Class 4 inhibits calcium entry. It really is just a masterclass in targeted chemistry.
But here is the stark, dark irony of cardiac pharmacology: pro-arrhythmia. The terrifying reality is that the very drugs we just discussed, the exact ones used to fix a heartbeat, can sometimes alter the underlying substrate of the heart and actually cause a brand new, potentially lethal arrhythmia. And the most notorious form of this pro-arrhythmia is torsade de pointes, which translates to twisting of the points. It's a rapid, polymorphic ventricular tachycardia where the QRS complexes literally appear to undulate and twist around a central axis on the ECG monitor. It's heavily associated with a delayed ventricular repolarization, specifically triggered by those Class 1A and Class 3 potassium-blocking drugs we just went over. When this happens, it requires immediate intervention, often with IV magnesium sulfate, and of course stopping the offending drug entirely.
Which leaves us with this final, really provocative thought. If the tools we use to slow the heart can stop it, and the drugs we use to stabilize it can throw it into chaos, how do we safely balance the pushing and pulling of these delicate electrical currents? Managing cardiac arrhythmias is an incredible, high-stakes tightrope walk of modern pharmacology. It demands a perfect understanding of exactly when to intervene in the human body's most vital electrical house and when to just let it be. Thanks for joining me for this explainer. I really hope it sparked your curiosity to learn even more about the amazing machinery inside your chest.